Good morning, everyone, and welcome to our Regaining the Momentum for HIV Ending the Epidemic. I will be introducing Ms. B.K. Hayes, MPH. She serves as the Acting Director for the U.S. Department of Health and Human Services, Office of Infectious Disease and HIV AIDS Policy, and the Executive Director for the Presidential Advisory Council on HIV AIDS in PASHA. In this leadership role, she is responsible for vaccines, immunizations, HIV AIDS, hepatitis, sexually transmitted infections, blood and tissue safety and availability, and tick-borne diseases. She also provides oversight for 5 departmental advisory councils and work groups. Prior to her current role, Ms. Hayes served as the Principal Deputy Director of OPIV and Executive Director of PASHA. Before her appointment with PASHA in 2012, Ms. Hayes served as the Acting Deputy Director and Senior Advisor for Policy for the HHS Office of Women's Health. Among her responsibilities were the formulation of budget, performance, and policy initiative for OWH, as well as management improvement and strategic planning. Before joining OWH, Ms. Hayes was Special Advisor to the Assistant Secretary for Health and 16th Surgeon General, and served as policy advisor with the Surgeon General on the health and medical team to assess the critical health needs after the U.S. Embassy bombings in Kenya and Tanzania. She also worked as the extramural community liaison for the National Center for HIV AIDS, viral hepatitis, STD, and TB prevention at the CDC, where she developed and strengthened national, state, and local organizational partnerships, including business, labor, faith, community, entertainment, and other non-traditional health partnerships. While at the CDC, her career included assignments with CNN Medical News as a producer and health policy advisor with the Congressional Caucus for Women Issues, where she worked on the Women's Health Equity Act and healthcare reform. Ms. Hayes received her bachelor's degree in rhetoric and communication studies from the University of Virginia and a master's degree in public administration from Georgia State University. With a concentration in strategic management and human resource management, while in graduate school, she was inducted into Phi Alpha Alpha National Honor Society, and she was selected as a Presidential Management Fellowship and completed her 2-year assignment at the CDC in the National AIDS Information and Education Program. She is proud to have provided advice, counsel, and implemented one of the most successful and longest running public health education and prevention campaigns for HIV and AIDS, American Response to AIDS and Business Response to AIDS. Ladies and gentlemen, I present to you Ms. K. Hayes.
Thank you so much, Erica. I'm gonna have to take you on the road and let you do the introduction. That was really, really special. Thank you. I wanna say that I am delighted to be here. It is my honor to welcome everyone to today's webinar as we leverage best practices, innovation, and health equity in ending the HIV epidemic in the United States. We're here today regaining momentum to end the HIV epidemic in the United States. We've all been super busy this past year as we talk about COVID-19 and our response. And our response continues. And HHS is deeply committed to ending the HIV epidemic in the US and abroad. A strong coalition of people with HIV, government leaders at all levels, community advocates, healthcare workers, public health professionals, HIV prevention, care, and treatment grant recipients, and other domestic and international partners have all dramatically increased access to critical HIV treatment and prevention tools. And this has enabled us to really strengthen our response in ending this epidemic. We want to continue and ensure that the momentum is in all sectors and we continue. We need to seize this opportunity to end the HIV epidemic. And we must bring the very best of America to this mission. I'm proud that the federal government has come in partnership on this initiative. and that we are working with relationships with diverse community-based organizations, networks across America. We need to talk about our innovative practices. We need to talk about challenges and how to maneuver those and pivot when necessary. And we need to really think about our response to HIV as we address individual, community, and structural factors and inequities. And these inequities really contribute to the spread of HIV. And I'm not saying anything new that you don't already know. I'm talking about stigma. I'm talking about barriers to accessing care. I'm talking about transportation needs. I'm talking about affordable housing and other social determinants of health. We have a real opportunity to end the HIV epidemic because we really need to build on the lessons that we've learned in the past 40 years. And we can take this journey together, and we have. There are tools needed to end this epidemic. And as you know, we will only be successful when we all work together to end this epidemic. Just 2 months away, we have World AIDS Day, December 1st. And the theme this year for World AIDS Day reflects this commitment: ending the HIV epidemic, equitable access, everyone's voice. We need everyone at the table. At the federal level, I am excited because the Assistant Secretary for Health, Dr. Rachel Levine, is a strong and passionate leader, and she has been committed to ending the HIV epidemic. We're excited because, as we say, one of our own, Harold Phillips, is at the White House as the director for the White House Office of National AIDS Policy. And we could not have a better and fearless fighter, friend, and leader in the White House. And we all work closely together. And then it's my federal colleagues. I'm talking at CDC, HRSA, NIH, the Indian Health Service, SAMHSA, HUD. We all have come together on this ending the HIV epidemic. And we meet periodically from a leadership perspective to talk about how are we doing? What are the next steps? What are our challenges? How do we maneuver those? So it is really a whole of government approach. I'm excited today, and I really want to do a shout out to some of the work that we're doing with what I call our PACE program. And that is prevention through active community engagement, what we call PACE. And this is a new initiative, fairly new, where we have very strategically placed our officers in 3 regions: Dallas, Atlanta, and Los Angeles. And so here today, we're being led by our Region 6 team, our PACE team, and also working in collaboration with the International Association of Providers of AIDS Care. As we talk about our PACE officers, they really have come together to end the HIV epidemic in 30 of the 57 prioritized geographic areas encompassing 15 states. And these officers work collaboratively with other OIDP staff under the leadership of Dr. Tim Harrison. Tim is the Deputy Director for Strategic Initiatives and also HIV Senior Policy Advisor. And he has a depth of experience. He leads our Minority HIV AIDS Initiative Fund. And he also brings the leadership for what I call our syndemic work, because we are strategically looking across HIV, sexually transmitted infections, and our viral hepatitis portfolios. And Dr. Harrison leads those efforts as we talk about, 1, releasing our strategic plans. And now we're in the implementation planning phase of what that looks like. So as we get ready for a wonderful agenda, when I looked at the agenda, I was like, oh, this is an amazing opportunity for this webinar today. Dr. Harrison will provide some remarks later. Our PACE officers are truly the key part of our Ending the HIV initiative, because from my perspective, they are in community. Those of us that are at headquarters, we're in the Washington DMV area, but our PACE officers are in communities. And I've heard, other colleagues say boots on the ground. I say heels, flats, whatever the case may be. But there are eyes and ears in communities on the ground, and that's a very critical role as we move forward. Again, welcome to this critically important webinar, and I will turn it over to Commander Luz Rivera, who is the Regional Director for our Region 6 PACE team.
Good morning, everyone, and thank you, Kay, for your motivational and great message. What a great way to start the Region 6 event. I'm Commander Luz Rivera, and I serve as the Ending the HIV Epidemic in the U.S. PACE Regional Director. Welcome to the regional Regaining Momentum, Ending the HIV Epidemic. Our goal is that, informed by your success and challenges, ensure that we provide answers that will assist you in the continuation of your efforts and end the HIV epidemic. We have spoken to many of you since we started in the region in 2019. Next slide, please. The PACE team serving you is, as you see in the picture, Lieutenant Commander Chavez. He's the PACE Deputy Director, and Lieutenant Erika Bazillons, that you already heard from her. She's our PACE Public Health Analyst. This team is committed to support your work and assure that your voice are heard and provide answers to your concerns. This event is one of the many ways we provide response to what the different community partners have requested. The Office of Infectious Disease and HIV AIDS Policy, Office of the Assistant Secretary for Health, along federal partners, state health departments, academia, public and private sectors, community and faith organizations, individuals living with HIV, and those at risk of acquiring HIV work together to end the epidemic. This is truly a whole of society effort. We want to thank everyone joining us during this 2 days as speakers, moderators, and co-hosts. You will hear from federal, state, county, academia, community organizations, and individual partners. A special thanks to one of our partners and co-hosts for this event, the International Association of Providers of AIDS Care and Fast Track City. Next slide, please. Region 6, ending the HIV epidemic in the US, we serve the states of Arkansas, Louisiana, Oklahoma, New Mexico, and Texas. Next slide, please. 2019, PACE have conducted multiple listening sessions with community partners. Next slide, please. We want to highlight some of the key findings from those sessions. You have expressed the need to enhance prevention and retention in care, meetings in non-traditional settings, and using multiple media vehicles for communications. The need for health literacy. Next slide, please. The attention to population that perceives themselves as invisible, like those that find it difficult accessing the HIV and ending the HIV epidemic decision tables, the need to educate those providing care on cultural and sensitive inclusive language, and the need to support community-based organizations serving priority zip codes. Next slide, please. The need to provide sexual health education, promote a culture of care, in addition of identifies specific zip code in which there were a high number of HIV cases, provide care to all individuals living with HIV or at risk of acquiring HIV. Next slide. To consider holistic care, community awareness, and their power to create changes needed to end the HIV epidemic, and the need to work together toward ending stigma and its impact on wellness and healthcare. Next slide, please. We want to remind everyone of all resources available at hiv.gov. Those resources are for you to use, and you can download and use for all of your ending the HIV epidemic efforts. Next slide, please. Here's our contact information. Again, welcome, and we hope we can all learn, discuss, and make new partnerships to end the HIV epidemic in the US. I will turn it over to our co-host for this event, Dr. Jose Suniga, President and CEO of the International Association of Providers of AIDS Care. Thank you.
Thank you very much. It's my distinct pleasure to join you this morning to open this workshop, Regaining Momentum to End the HIV Epidemic in the United States. Bienvenidos también a mis amigos y amigas de habla hispana. My name is Jose Zuniga, and I'm president of IAPAC, but also the Fast Track Cities Institute. This workshop is made possible through largely an initial conversation that I had with Commander Rivera and ultimately with Lieutenant Commander Chavez as well, who quickly agreed, we all agreed that it was important to start sharing best practices, not just amongst domestic HIV responses, but also international HIV responses. And so we are excited that we are going to be joined by various fast-track cities around the world that are doing exceptional work in closing gaps across the HIV care and prevention continuum, but also in addressing some of the challenges we face, cross-cutting challenges, including stigma, discrimination, disparities, and inequities. Next slide, please. Next slide, please. Well, while we try to sort this out, I'll take this opportunity also to thank our colleagues at OASH, HHS PACE Region 6 program, our faculty, and all of you who are participating in this day-and-a-half workshop. Not quite sure what's happening with my slides, but in the interest of time, I'll continue and just say that I'm here representing both IAPAC, but also the Fast Track Cities Initiative, which was launched on World AIDS Day 2014 in the city of Paris. We started out with 26 cities signing the Paris Declaration on Fast Track Cities. And as of today, we count on more than 350 cities around the world that have joined this network. There is significant overlap between the Fast Track Cities network in the United States and the Fast Track Cities network in EHE jurisdictions. As you'll know from the slide, all of the little red flags are existing Fast Track cities. And in Region 6, the majority of our Fast Track cities are located in the state of Texas as well as Louisiana. Efforts are ongoing to recruit additional EHE jurisdictions, including entire states, to join the network. Next slide, please. I'd like to make clear that as part of the initiative, we make sure to align with national and sometimes regional HIV responses. So in the United States, we've gone through great effort to align our activities with the EHE strategy. But I'll just highlight some of the elements of the Fast Track Cities initiative that I believe are complementary to the ND epidemic strategy, and in some ways add value to the work that the ND epidemic strategy is currently advancing, particularly since the Fast Track Cities initiative recruited the first series of Fast Track Cities back in 2015. And I'm proud to say that an incredible amount of good work has been done by communities in the various Fast Track Cities in the United States since then, that I believe has contributed to being leveraged for forward momentum, including during the COVID-19 pandemic. So Fast Track Cities is really a framework for broad stakeholder engagement across the entire network. We are very proud of the fact that there are a variety of stakeholders who are brought into the loop and made a part of implementation planning, monitoring, delivering of services, and ultimately the sharing of best practices, because it's for our firm belief that a high tide can lift all boats. We provide supportive resources that include technical guidance, sharing model implementation programs, not just from the US. We have routinely shared implementation plans from, say, Phoenix and other cities in the US, but also our cities around the world that are really delivering across the now 95 targets and addressing those social and other barriers to improving HIV care and treatment continua, including, for example, the City of London, from which you'll hear shortly. There are monitoring tools that we also develop, specifically dashboards for each city and county that joins the network. These are not competitive in any way with any national or other city dashboards. We try hard to work together with local, sub-regional, and national stakeholders to ensure that these tools are complementary. There are capacity building modules around continuum optimization and stigma elimination. Best practice sharing is already noted, including through a best practice repository where we collect best practices from a variety of cities. We evaluate them and we put them out to the entire network of 350 plus cities. There are assessment tools as well around quality of life, quality of care, and most recently a health equity assessment, one that we launched earlier this year around LGBTI plus health equity. We produced a report from that was released at World Pride in Copenhagen earlier this year, and I encourage you all to see it because it includes the United States, and not surprisingly to many of you who are out in the field, we noted significant health inequities within this key population. I noted already the exchange of best practices. This includes through communities of learning, and they're meant to contribute to a way of sharing information across jurisdictions of similar jurisdictional structure and epidemiology to address social and structural barriers that are affecting key populations. And finally, there's a key area of focus around social enablers to optimize HIV health outcomes, because as we all know, we can't treat our way out of an epidemic or even rely on combination HIV prevention to end the epidemic. There are so many other issues that we must address holistically if we are to ensure a quality of life for people living with and affected by HIV that is commensurate with our responsibility to deliver said quality of life. With that, next slide, please. I end by wishing you all a very productive workshop, but also want to highlight that in the coming year and through the rest of this year, we will be busy as an initiative and an association trying to find ways of assisting the ND epidemic plan around regaining momentum, not just in relation to HIV, but hopefully also in relation to other diseases such as viral hepatitis, HBV and HCV, of course, HCV having a cure, and also coordinating urban combination HIV prevention agenda that's based on the UNAIDS Global Prevention Coalition 10-point action plan. You'll learn more about that during the international panel later today. But with that, again, have a productive workshop. Thank you very much to our colleagues at the federal agencies and all of you who are participating from Region 6. Thank you.
Hello, good morning, everybody. My name is Dashel Sears. I am the Director for Advocacy and Public Policy here at IAPAC. I'm going to go ahead and share my screen now. Again, welcome to all of our attendees who are attending today's workshop. I do have a couple of housekeeping notes to ensure that we have a smooth conference first. Smooth workshop first. We ask all of our speakers to keep themselves muted to ensure we reduce noise interference. And we are asking attendees if they can submit questions to our moderators through the chat function. We're going to have a break at 12 for lunch, and at 12:30 we'll return to join back for day one, part 2. I'm going to go through quickly the agenda for today. We have our keynote address starting at 9:30. We have our first international panel and follow-up Q&A session. We'll then have lunch and return back to our domestic panel with another Q&A session. We'll then have a brief break and come back for 2 presentations. And finally, we'll end today with closing remarks by Dr. Dimitri Daskalakis. With that, I'm going to turn it over to our Lieutenant Commander Rodrigo Chavez from PACE Region 6. But I do want to give a thank you to our partners at CVent. I want to give a thank you to Commander Luis Rivera and Dr. Suniga for incepting this event and generating the process to get this started. I also want to thank our internal coordinators, John Charles, our Lieutenant Commander Rodrigo Chavez, and Alex Vance for their help in coordinating and organizing this. Thank you very much. And Lieutenant Commander Chavez, I'm going to go ahead and turn it over to you.
Good morning, everyone. It is my pleasure to introduce Dr. Timothy Harrison. Dr. Harrison is the Deputy Director for Strategic Initiatives and a Senior Policy Advisor in the United States Department of Health and Human Services, Office of Infectious Disease and HIV AIDS Policy, OIDP. He is also currently serving as OIDP's HIV team lead. He provides leadership and support on a range of programs, policies, and activities in response to the U.S. domestic endemic of HIV, viral hepatitis, and sexually transmitted infections. Dr. Harrison's primary responsibilities center on the management and oversight of the Minority HIV/AIDS Fund and OIDP's sexually transmitted infection portfolios. His work has focused efforts to reduce infectious disease, health disparities, and improve health outcomes for racial and ethnic minorities, including sexual minorities among them. He has worked to support, develop, and implement new strategies to increase access to prevention, care, and treatment services for vulnerable communities by addressing social and structural determinants of health, supporting innovation and collaboration, and by prioritizing population and geographic communities disproportionately impacted. For more than 20 years, Dr. Harrison has worked to advance the concerns of equity in the social safety net in public health spaces. Prior to joining OIDP, he worked as a policy analyst in the area of low-income housing, welfare, and workforce development, was a visiting fellow at the University of Rochester Government Department and Frederick Douglass Institute, and an adjunct professor of government at Georgetown University. He holds a Master's of Art and a PhD in Political Science from Northwestern University and a BA in Political Science from Swarthmore College. He happily resides in Washington, D.C. Dr. Harrison, thank you for all the work you do for us, and the floor is yours. Thank you.
There we go. Can you hear me okay now? All righty. Thank you, Lieutenant Commander Chavez, for the introduction, and thank you for the invitation to be here this morning. I'm hailing from Washington, D.C. This morning. Thank you also to Commander Rivera for the invitation. And I also want to give a shout out to Captain Naran Masudi, who is the Regional Health Administrator for Region 6, and really to all 3 of you for your leadership in that region. for HIV and other issues of a great importance to public health. So thank you for the chance to be here today. So much I want to get into and talk about, but I thought first, just to sort of situate a little bit about what office I'm in and what we do, so you have some perspective for those who may be unfamiliar with the Office of Infectious Disease and HIV AIDS policy. As this slide reflects, our mission is to provide leadership and management in a range of public health issues in OASH, which is the Office of Assistant Secretary for Health. Our office reports directly to the Assistant Secretary for Health, Dr. Rachel Levine. Next slide. This is just a glimpse at the portfolio within OIDP. In addition to HIV, and I will say that the office began, many of you may know, as OHAP, which was just the Office of HIV AIDS Policy many years ago, and has evolved over time to include viral hepatitis and sexually transmitted infections and vaccines and antimicrobial resistance and blood and tissue safety. Our office also manages 5 federal advisory committees, including the Presidential Advisory Council for HIV AIDS and others. And of course, our office houses the HIV.gov communications portal network that many of you use. Next slide, please. And again, this is just a little graphic of how our office with regard to HIV is set up. In addition to working on ending the HIV epidemic, and again, in addition to the Presidential Advisory Council for HIV AIDS, PACHA, we have HIV.gov. We also work with the National HIV Strategic Plan. As you know, that was released in January of this year. And we also manage something called the Minority HIV AIDS Fund, or MAIF. And we'll talk a little bit more about these things moving forward. And as you'll see on the far right, we also manage the AHEAD dashboard and the Ready, Set, Prep program. And we also have our PACE officers, including here in Region 6. Next slide. This slide, or ones like it, are familiar, I'm sure, but just to sort of situate us in this conversation, we're talking about ending the HIV epidemic. The effort is in 48 counties, DC and San Juan, which account for more than 50% of new HIV diagnoses in 2016, and of course, 7 states with a heavy HIV burden in rural areas. Next slide, please. Our goal remains to reduce number of new infections by 75% by 2025 and by 90% by 2030. Our effort is a collective of federal agencies involved in this, those directly funded for EHE and others who have been brought on in collaborative fashion, like SAMHSA and UD and others. We meet regularly to talk about those issues that are really of necessity as we move forward collaboratively to end the HIV epidemic. Next slide. And of course, these key EHE pillars should be familiar to you. Diagnose all people with HIV as early as possible, treat HIV rapidly and effectively to reach sustained viral suppression, prevent new HIV transmissions by using proven interventions, including PrEP and SSPs, and of course, respond quickly to potential HIV outbreaks. Next slide, please. EHE updates. Next slide. I want to start here. It was interesting a couple of weeks I guess it's been a couple of weeks ago now, that Dr. Dimitri Daskalakis from CDC posted a blog on hiv.gov, and it essentially was a recap of a presentation that he did at PACHA, the Presidential Advisory Council. I wanted to bring this up to sort of get us into this conversation about regaining momentum, to talk about the shared journey. I thought it was quite telling that CDC was able to extract themes that surfaced in the community EHE plans. And you may recall that in 2019, through funds from the Minority HIV Fund, we funded CDC to begin doing the initial planning, if you will, for EHE. And some of these perhaps are not a surprise, but I think it's worth actually sort of spending a little time sort of noting. When you talk about those 57 jurisdictions and the 32 plans, and what were the themes that emerged from those? And I think it's important for us to just take a look. Over 80% of the HE area plans to increase access to use and use of HIV, plan to increase access to and use of HIV self-tests, as well as conduct targeted testing in non-healthcare settings. Over 60% of the EHE plans plan to expand telemedicine services. Over 70% are planning to expand PrEP linkage programs and establish or expand syringe service programs. At least 50% of EHE areas also plan to establish a dedicated response workforce and improve the use of real-time information to direct resources. 27 areas also address the syndemic. I heard that earlier, Mr. Suniga. The syndemic of HIV, STIs, viral hepatitis, really important. And 25 address the opioid crisis. 22 included strategies to improve HIV prevention education in K through 12 schools. And not surprisingly, over 70% of the jurisdictions identified economic insecurity, education, housing, access to healthcare, and stigma as significant structural barriers. Next slide, please. Most recently, President Biden has requested $670 million from Congress to help end the HIV epidemic. The current administration is committing to help accelerate and strengthen efforts to end the HIV epidemic in the United States. Federal, state, and local EHE agencies have maintained a balanced approach, continuing to deal with COVID and all the resulting emergency needs from that, as well as continue to work in HIV. It's been a challenging 18 months. And as we know, some of the services, the attention to it have been diverted. The desire to get tested, to get folks into care services has been a challenge. But the administration has really signaled its commitment to the ending the HIV epidemic. And we want to ensure that while we are faced with these other challenges, our work in HIV continues. Next slide. I wanted to just show you a little bit about within the Office of OIDP and OASH, our piece of the collective response to the EHE effort. Your other federal partners, or some of them who will be speaking at this workshop, will provide a more in-depth lens of their particular agency efforts around EHE. I wanted to sort of talk a little bit about OIDP and our role in this. In addition to serving as a communing, as a collaborating entity, convening entity for our federal partners, bringing us together to collectively work on EHE, there are some specific elements that are particular of note, including the fact that we have placed in regions 4, 6, and 9 commission officers who have been hired to really help continue and extend the EHE effort out in those regions, including Region 6, which of course includes Texas, Arkansas, Louisiana, and Oklahoma, and New Mexico. I believe I got that correct. Invaluable efforts in those regions to help serve as public health educators and coordinators on EHE strategies, interventions, and messaging, really engaging the public in public forum and community centers, and really serving as force multipliers for our effort. And the intention to place the Commission Corps officers in regions 4, 6, and 9, of course, had a lot to do with the need for attention in those regions. And we are looking potentially at how we might expand on some of those that presence into other regions. Next slide. Hopefully many of you or all of you are familiar with the AHEAD dashboard, America's HIV Epidemic Analysis Dashboard. It is now going into year 3 shortly, and has been built with the design of providing a tool or resource for jurisdictions to better understand what's going on with EHE. The data that is currently on there provides information on the 6 core indicators. And most recently, we have added social determinants of health to the dashboard, as well as disaggregated stratified data by demographic breakdowns. And it is an evolving resource. We continue to want your feedback on how it is serviceable for your purposes. So if you haven't taken a look at it recently, please do so. I know my colleague, Oskian Kazulian, who is leading this effort on the dashboard, will be presenting, I believe, tomorrow. And so please listen in on his session. We think that the dashboard really is an important tool in this conversation. And I think in some measures, I like to say, helping to democratize how data is accessible to folks. And we continue to, as I say, seek your comments and input on how we can continue to improve the dashboard moving forward. Next slide, please. Ready, Set, Prep. I think many of you are familiar with the donation of the 200,000 doses of PrEP medications to HHS a couple of years ago. With that, we have built a distribution mechanism program for Ready, Set, Prep. And this again is something that has sort of taken on a life of its own, if you will. It's been a considerable amount of time and effort looking to improve the program, to improve enrollment. It has not been without such challenges, as I think have been well documented. But we are looking for ways to continue to expand the program in terms of the pharmacy involvement. And our campaign efforts, many of you perhaps have seen some of these things out there to encourage folks who are indicated for PrEP to consider Ready, Set, Prep. And if not Ready, Set, Prep, some other PrEP program, quite frankly. We want to increase the numbers, particularly those racial and ethnic minorities who have not in proportion been accessing PrEP as indicated. So we currently are working, doing some assessments of the Ready, Set, Prep program to see how well it's working, what are the challenges, the gaps, what are its needs in order to make it a better program. And over the years, we've gotten great feedback from many of you and others on how Ready, Set, Prep can evolve to be a better program. So stay tuned for more on that as we continue to move forward. Next slide, please. So what's next? Next slide. You know, in thinking about the theme of this conference, the sort of regaining momentum into the HIV epidemic in the US, I was sort of, as I was preparing for this talk, thinking about this idea of regaining momentum and what does that mean? And of course, there is the presumption that we've lost momentum, right? That we are not moving forward as we once were, that we are perhaps stuck, that we are not moving at a pace that we would like. And of course, the challenge over the last 18 months of a pandemic could be one reason for that. It could be a change in administrations. It could be any number of factors. But there seems to be this belief that we need to regain momentum. And as I was thinking about the sort of doing my own sort of homework, there were lots of articles and the like that sort of talk about how you regain momentum, and much of that sort of is at the sort of individual level, which sort of talks about folks who are in a rut, either in their workplace or in a rut in their life, and are stuck. But I found this particular article by Cam Taylor, and I thought it had application not just to the sort of individual, but potentially application to us as a collective who are interested in ending the HIV epidemic. And then in this 6 proven ways to regain momentum. First one, acknowledge you are stuck. And I think we all are sort of doing that assessment of where we are in our work in HIV, to understand what are the challenges, whether it's COVID or others as mentioned, to acknowledge that perhaps we're not moving as we need to be in terms of getting to the 2030 goal of ending the HIV epidemic. Assess your readiness. Are we really prepared to do the work, the collective work, the collaborative work, the hard work that's necessary to end the HIV epidemic in the US? Articulate clear intentions for what you want. What are the goals? How do we get there? What are the things that need to be done in order for us to end the HIV epidemic in the United States? Attach a link from existing momentum to where you're stuck. There's a tendency to sort of paint the sort of overall picture that everything is stuck, or everything is not working, or everything is not moving. And that's not the case. There are some things that are working. There are some things that are moving forward. Let's understand those, celebrate those, scale those up, talk about them more, and connect them to those things where we're challenged and need more work. Ask wise people for help. Well, that's why I'm coming to you. Many of you, collectively, we will end this epidemic. Not just federal, not just state, not just local, not just public, not just private, all of us. What is the wisdom, the collective wisdom we have over 40 years of experiences of working in this field to end this HIV epidemic? And apply yourself to daily action. And it's like, what can I do? What can we do individually, collectively, to end the HIV epidemic in our work? And then a final thought here from Mr. Taylor: focus on one day at a time, and don't let the mountain ahead overwhelm you. Momentum is your friend, but must be coaxed up the path one step at a time. Next slide. As we're looking ahead, of course, we're not out of the pandemic. We've made great strides. I'm hoping folks are getting vaccinated. I'm hoping folks are taking care of their mental health. But there is still much work to do in terms of ending the COVID-19 pandemic as we address HIV. During this past 18 months, many of us have had to pivot and reassess in terms of expanding telehealth service, telemedicine, self-testing. Please go back. And others that have been really essential to our work, expanding partnerships that are essential to our work during this COVID period. And I think many of those innovations and lessons learned and best practices must and will carry over as we look at a day of beyond COVID. Next slide, please. Further looking ahead, and this need for renewed commitment and vigilance, and it's identified a few things that I think are really essential. And I think, and special thanks to my Region 6 colleagues for helping to sort of put this list together that I think are really critical as we talk about regaining momentum. Review and analysis and use of data-driven approaches for disease intervention and disease disruption. Learn about and adopt innovative community engagement strategies. We were fortunate a couple of weeks ago within HHS to have Dr. Levine, the Assistant Secretary for Health, talk to the federal agencies about the importance of doing some assessment of where we are, including, and really importantly, the community engagement strategies that are in place and how well we're doing with community engagement. And is it ongoing? Is it meaningful? And I think we all are importantly challenged to ensure that whatever we're doing, that communities are actively involved from the start and are really a critical piece for our success. Amplify and replicate successful community approaches. And I think we have learned to talk about issues of equality and equity, inclusivity and diversity. We have a bit more to go about being intentional in practice. Exchange ideas and best practices and innovations from frontline efforts. Sometimes I don't think we do enough about talking about what's working. Where are the success stories? And how do we replicate them? How do we scale them up? Develop and introduce strategies to address stigma, behavioral health needs, and other social determinants of health, reduce health disparities, and promote health equity. I was very fortunate to partner with the Office of Minority Health around a anti-stigma HIV challenge, many of you may have heard of, which is beginning this week with receipt of the submissions for that challenge. The role of stigma is certainly something that hovers over much of the work that we do, whether it's in Region 6, Regions 4, 9, 3, 2, 1, you name it. Stigma is a huge issue. And I think we need to be continually looking for practical solutions to address stigma. The social determinants of health, as we all know, it's been said, I think, enough times that many of the biomedical solutions to our efforts are critically important, but they will not succeed unless we begin to seriously look at how those other barriers, those social determinants of health, are impacting the lives that we're looking to assist, whether it's issues around housing, issues around insurance, issues around poverty. What are the solutions, the practical solutions that could be in play to help tend to the whole person? And issues of health equity. I was very pleased with the new administration's very active and proactive discussion around issues of health equity. And what does that look like? And how does that manifest in the work that we do? Next slide. I mentioned the Whole of Society initiative. This is a chart that we've been using for a couple of years now, which shows all the different components of this Whole of Society initiative. I gladly included a new bright yellow box that includes fast track cities in this conversation and in partnership. And we know that the fast track cities, I think more than 30 of them are really involved in this effort and are aligned, as was mentioned with the EHE effort. We welcome as a partner with the same goal of really ending the HIV epidemic. Next slide. Before I wrap up, I just had a couple of thoughts sort of away from the slides that I just wanted to share. And a lot of this, I think, had to do with some of my thoughts as I was preparing for this presentation. When I was asked to speak and keynote this workshop, initially I was reluctant, and I wanted to decline, and I wanted to decline because I wasn't sure if I was necessarily the right person to do the keynote. But after years of presenting at conferences and meetings and years of teaching, I was really accustomed to that sort of in-person engagement, right? And where you sort of get the energy and you see the faces, the full person, not just the cutoff versions that we've all become accustomed to over the last 18 months. And you sort of feed on that energy. And I wasn't so certain that I am what we call virtual ready to do these types of engagements. But I decided to do it anyways. The keynote, I think, is really important as you guys begin your work as a point of sort of setting the stage for the 2 days to provide perhaps a challenge or inspiration for you to continue on for the next couple of days. And so I take that seriously about the important role that it has. As we're talking about, in this instance, regaining momentum, and in that spirit of sort of setting the stage and inspiration, I look back just a few months ago, I guess, to June 5th. And this was, of course, the commemoration of the 40th anniversary of our recognition that we will have a new pandemic on hand called AIDS. And it was in us all thinking about this 40 years of HIV, where many of us have been involved in this fight, this struggle for decades even, where reflections on the challenges and struggles of the last 40 years came front and center, as well as on a personal level, the losses for many of us, the personal losses of friends and family and colleagues and coworkers. And it provided a sort of a time to sort of think about what the last 40 years have meant. But it also was a signal of hope. It was a signal that we have made great strides, that we are not where we were in the 80s and early 90s, that we've made significant strides, and those should be celebrated. And we have made important gains in the science and in the strategies and how we respond, and the awareness of those missteps along the way. And I think it's really important to acknowledge those as we move forward. And I think, like many of you, I sometimes struggle with some of the frustrations that persist as we move forward. But I'm heartened and I'm optimistic that we are on a path to end this HIV epidemic, and it's something that I think was perhaps unmanageable even a few years ago. And so I stay in the fight. We stay in the fight because of that hope to end this HIV epidemic. On June 5th, President Biden also offered his remarks in commemoration of the 40th anniversary. And I thought I would just sort of leave you with those, and as a reminder too of the important work that lies ahead and the acknowledgement of the past. And this is just an excerpt from those. I'm sure you've heard them. Despite the progress we've made, our work is not yet finished. In honor of all those we have lost and all those living with the virus, and the selfless caregivers, advocates, and loved ones who have helped carry the burden of this crisis, we must rededicate ourselves to reducing HIV infections and AIDS-related deaths. We must continue empowering researchers, scientists, and healthcare providers to ensure equitable access to prevention, care, and treatment in every community, particularly for communities of color and the LGBTQ+ community. And we must provide moral leadership to eradicate the stigma and discrimination still faced by those living with HIV, rededicating ourselves to continuing the vital work of ending this epidemic once and for all. As you go about your work through the next 2 days of discussions, as you think about what it means to regain momentum, I hope these words offer or serve as some reminder of the work and challenge ahead, the great opportunity that exists for us all to collectively in the HIV epidemic. I want to again give special thanks to Commander Rivera for the opportunity to speak this morning, as well as to Lieutenant Commander Rodrigo Chavez, and again to Captain Miran Masudi, who is the Regional Health Administrator for Region 6. Thank you.
All right, thank you so much, Dr. Timothy Harrison. We're going to go and enter a break, and we will return in about 15 minutes. So we're going to go ahead and say we'll return at around 10:15, and we'll go into our international panel. Thank you very much. We'll see you back shortly. I'm going to give people a few more minutes to just come back if needed, and then we'll start. Okay, so we are going to be joining our international discussion panel today. Our moderator for this discussion panel will be Ms. Frances Wallace. Fran Wallace is the Executive Director of the Office of Health Policy and AIDS Funding, a division of the New Orleans Health Department. Fran holds a master's degree in health administration and has spent the past 20 years working in HIV care. Her particular area of focus has been community-based care for populations disproportionately affected by HIV. She spearheaded the creation of the Fast Track City Steering Committee in New Orleans and is an ardent supporter of ending the epidemics. Ms. Wallace, take it away.
Thank you. Good morning. I'm very pleased to present this segment, Learning by Doing, International Best Practices and Innovations. You know, there's some very exciting work that's taking place globally, and we want to share that with you this morning. Our first speaker today is Professor Jane Anderson from Fast Track Cities in London, and she'll talk to you briefly about optimizing HIV testing and linkage to care. Jane?
I'm trying to unmute myself. Okay, I think I'm alive. Yes, does that work?
We hear you.
Hooray, great.
Yes,
No, I couldn't switch myself on, but now I have, so that's great. So hello, good day, everybody. Hello from London. My name's Jane Anderson, and as Fran said, I'm a consultant physician. I've been working in HIV for a long time, longer than I care to remember, and I co-chair the London Fast Track Cities group. So if I could have the first slide, please. I want to start off by just setting the scene for you. I've been asked in 11 minutes to tell you about a few things that have worked in our city, but just to tell you a little bit about the sort of city it is that we're working in. So it's a huge city. We're nearly 9 million people. We've got about 39,000 people living with HIV in London, and that's about 40% of the entire UK population of HIV positive people. So London has and HIV are, they're important to each other. Now, we're not just one city, we're made up of 33 local boroughs. And that's really important because each area has autonomy and it has political leadership. And the responsibility for public health sits at that level. And HIV prevention and testing sit at that borough level, so that 33 split. So that's really important. Now, as well as the 33 local boroughs, we've got 44 acute hospitals. We've got 28 HIV clinical centers. Now, really important, and I don't know how this resonates with other people, they're open access. Doesn't matter where you live, you can walk in to any HIV center of your choice. And everything that is done in terms of diagnosis, prevention, treatment, and care is free of charge in those centers, whoever you are, no matter where you come from, no matter your immigration status. We fought for it, but it's central, I think, to a lot of what we've managed to do. We've got about 50 plus HIV specific voluntary organizations in the city, but many, many more that are dealing with the issues that are really important for people living with HIV as well. We've got about 1,500 primary care organizations. Now, all of that is a lot to start with, but it's complicated by the fact that the money depends on which organization you are, where you are, and for the funding to cross boundaries is really complicated. So a lot of things risk being in silos. Next slide, please. Now, we're doing really well, and we've been doing very well against the 1990 targets, as you can see here. And in 2019, London was the first global city to pass 95, 95, 95, and we are really proud about that. However, these things don't happen overnight. This reflects 40 years of work by many, many people and many, many organizations. And so this is the cumulative effect of many years' work. But by the end of 2019, 95% of people with HIV in our city knew about their infection. 98% of those were diagnosed and in care, and 97% have an undetectable viral load. Hooray, you say, but, and there's a big but, ensuring the remaining 5% of people who are undiagnosed are able to get tested needs a really different approach from when you're just testing for everybody. You have to be much more tailored and think much more strategically about who is that 5% and how are we going to find them. Next slide, please. Now, that all looks fine, that's London, but our city, as I've said, is not one whole thing. It's lots of different bits, and it's not a uniform picture. So if you can see the dark blue bits, that is the highest seroprevalence of HIV, tends to be in the center of the city, high prevalence, high incidence. But the paler blue areas, the donut on the outside, if you like, those are the areas where there's a lot of late diagnosis, there's a lot of undiagnosed infection, even if the prevalence is a bit lower. So again, we're having to think how to approach these in a different place-based approach. Next slide, please. So if I think about the testing services we have in London, on the whole, about 80% of our tests are carried out in sexual health clinics or in the context of antenatal screening. And we're making really quite slow progress in getting other healthcare settings to pick up on HIV testing, even though government advice is that every contact with a healthcare professional in our city should be able to offer an HIV test. It's still not happening. Now, it's really important that we have different settings, because we know that different settings have different users. And in general, there's this kind of phrase people use about, oh, hard to reach populations. No, people are not hard to reach. Our services are out of their reach. And so lots of different front doors are really important. And though overall 80% are carried out in sexual health clinics, we need to be looking for other places. And we have tailored outreach for populations with higher prevalence. We know that gay men prefer to test in sexual health clinics. Black ethnicity often will prefer to go to the GP. And I'm not going to touch on home testing, COVID, digitalization, whole programs. I mean, we could talk for hours about that on its own. Next slide, please. Now, I've been asked to try and find 3 examples of what I would consider to be good practice that illustrate 3 different kind of principles and parts of our jigsaw, if you like. So I'm going to start with the London HIV Prevention Programme. It's been running since 2015. And the reason it's so important is that it is a collaboration. And it's a collaboration across all those 32, 33 different areas of London. Each area puts a little bit of money in, and it's all spent collectively. And another great saying, and that is that progress moves at the speed of trust. So collaboration and trust in this process have been fundamental, and it works. The strapline is do it London, do it testing, do a test, do PrEP, do condoms, but it works across the city with multiple partners. And that's why it has been so successful, is because it has actually got that collaboration. And there's a lot of really important innovative testing work coming from that. The next slide also shows you collaboration, but this is much more about collaboration with a particular community. And this goes back to my point about putting things within people's reach. Now, this is a particularly successful model I'm going to tell you about. And it's about how combination prevention has worked in one specific clinic in the centre of London. But it applies to more than that. In 2016, we saw 5 of our 28 clinics reporting a new drop in diagnoses. Not a drop in the number of tests, a drop in the number of diagnoses. And this clinic, 56 Dean Street, had the biggest fall of all. And between 2015 and 2017, 80% fewer new HIV positive people were seen, despite testing going up. And the secret to this, and there's a paper which I've cited at the bottom, they won a prize, was just being incredibly responsive and designing the service and engaging with the at-risk communities. It promoted increased frequency of testing and very rapid treatment initiation. So it went from getting a test, waiting for the result, having a chat, thinking about treatment, weeks could go by. This is starting treatment either on the same day or within days. And that means there is very little time between getting tested and getting to viral suppression and being uninfectious. And at the same time, even before it was available in the UK, this particular clinic really pushed PrEP and got that going. And it was in response to LGBT service users in that part of London who could use it in a way that made complete sense to them, and it works. The next slide, however, which I very briefly want to just touch on, because I know I haven't got much time, is thinking about collaboration again, but this is one about service providers collaborating, if you like. This is an initiative which I was part of, and was putting point of care HIV testing into the hands of primary care nurses. Now, they started off by saying, oh my goodness, we can't do that, it's too difficult, or we don't know about HIV, but actually the collaboration between primary care, secondary care meant that this happened. We did it as a trial, but we found the results in a summary, in a nutshell, it's acceptable, it's effective, it was safe, and the fears of the nurses weren't realized, they could manage, and it worked. And it delivered increased testing and earlier diagnoses, higher CD4 counts at diagnosis. And it was reaching those people who tended to present late. We were also finding people who had known they were positive, but had disappeared from care, getting retested and re-engaged. And when we did a cost effectiveness analysis, it was worth it for the money. And that's now being implemented into routine care across some of the boroughs in London, not all of them. So we're still away from this being a citywide initiative. It's focused, and it worked because it was partnership, and a lot of the leadership was from the primary care teams. So next slide, please. To finish with, I just want to point out that, yes, we're talking here about local responses in London, but it seems to me to be critically important that we are all aligned with the same strategic goals. So in our country, we're very lucky. The government has sort of picked up on HIV for the moment. Our last health department did. Sadly, he's been sacked. We've got a new one. We don't know how that's going to go, but the previous health team said we will get to 0 by 2030 nationally. We also had the HIV Commission, which was led by the voluntary sector, which has done a piece of work that underpins the action plan that is coming from that, and it focuses on testing, testing, testing. And as Jose Zuniga said, and as Fran has said, we are part of a global network. Fast track cities, we've got each other, we can talk to each other, and we are all moving behind a common purpose. And that leads me to my final slide, which is just a picture of our website, London Getting to Zero, Fast Track Cities. This is our kind of logo for our city from Fast Track Cities. But we'll only do it with trust, collaboration, and a lot of testing and a lot of linkage to care. Thank you.
Thank you so much, Jane. All right, and our next speaker is Mr. Jamoki Patrick, who will speak on expanding demand and access to PrEP. He's from Kingston, Jamaica, and he comes to us with the innovative practices in Jamaica. Thank you. Would you unmute?
All right, sorry about that. I was trying to unmute, but it wasn't allowing me. Am I able to share my screen? It's not allowing me to. Host disabled participant screen sharing, not sure. But in the meantime, as we get that sorted out, hi everyone, my name is Jumoke Patrick. I'm the executive director for an NGO here in Jamaica that provides advocacy for people living with and affected by HIV. I'm also a part of the larger HIV response here in Jamaica that works within the treatment, care, and support aspect of the response here in Jamaica. My presentation today is about the expanding of PrEP, what that looks like in Jamaica, where we are as a country, and where we need to go. So that's what my presentation will be about today. And I'm still unable to share my presentation, but if the organizers have a copy of that and can project, I'll appreciate that.
Okay, Jamoki, we're trying to get you some assistance right now, but you can begin your presentation. Why don't you go ahead and begin your presentation, and I'm sure the slides will come later.
All right, I believe it's sorted now.
Okay.
All right, hi everyone, my name is Jumoke Patrick. And let's begin. My presentation today will be about the expanding demand and access to PrEP, more so for here in Jamaica and where we are as a country. And let's begin. So, why PrEP? Here in Jamaica, we have an HIV prevalence of 1.5% of the general population. And there is an ongoing transmission despite increased access to ART, which is treatment as prevention here in Jamaica. And if you can see from the slide, it gives you a summary from 1989 up to 2007 of HIV seroprevalence in STI clinics across Jamaica. By 2021, it is our hope that we'll at least reach the 90, well, this year, by the end of this year, it is our hope that we'll reach the 90 targets. Currently, we are not there. We're a little bit under 80% for the first 90. We're way off in terms of persons retained and in care. And in relation to viral suppression, we're a little bit under 60% of those persons who are on care. So this presentation, by the way, it's because PrEP is new for Jamaica, unlike our other partners in different countries and in the global north, we're pretty much just coming to the table in terms of providing PrEP for our clients, in terms of talking about PrEP here as a country. So this presentation is really what we have been using so far to sensitize partners, stakeholders, and the community about the offerings of PrEP here in Jamaica. So our PrEP should be promoted as part of a combination prevention approach here in Jamaica, whether it's condom, counseling, post-exposure prophylaxis, treatment for STI, male medication, male medical circumcision, and ART for partners living with HIV. I think we all should know what PrEP is, but I have a couple of slides here just talking about it. In Jamaica, the combination drugs that we're using in relation to PrEP is tenofovir and emtricitabine as a single dose fixed dose combination for persons who wish to go on PrEP. It was approved by WHO in December 2015. And it's, as like I said, in combination with safer sexual practices. For us in Jamaica, PrEP, we are targeting those populations that are most at risk for having unprotected sex, and well, those persons who are having unprotected sex. So as you can see from this slide, key populations most at risk for having HIV, including sex workers, men who have sex with men, adolescent girls and young women, transgender persons and prisoners, serodiscordant couple. But the bottom line for this is that anyone who has perceived themselves to be at substantial risk for HIV can be placed on PrEP by a healthcare provider or site. Contraindications to PrEP. PrEP should not be provided if somebody is HIV positive, evidence of possible acute infection, suspicion within the window period for exposure, adolescents, poor kidney function, and unwilling or unable to return for a 3-month clinic, for a 3-month visit to the clinic for a test. An assessing of risk is a part of the process. And that is what we have been doing as a country when it comes to PrEP. Now I'm going to go a little bit closer to, and these are all slides in relation to PrEP, which I believe most of the persons on this call would have been familiar with, but I want to go in terms of the introduction to PrEP here in Jamaica. So PrEP in Jamaica has been on the increase in terms of persons and clients asking about it, based on what they would have seen on social media and what they would have seen through media from other countries. We also recognize within key populations in Jamaica, especially men who have sex with men and the transgender community, there is a high rate of infection among those communities. In 2020, the Jamaica AIDS Support for Life, which is one of our first NGO here in Jamaica to provide treatment, and our government partners participated in a pilot program from June to September. 50 known men who have sex with men were participants in the pilot, and all clients were over the years of 18 and had a history of unprotected sex. On completion of the pilot, the Jamaica AIDS Support for Life, which is a civil society partner, undertook a communication program in relation to providing information, sensitization session, and just the general education of people about PrEP here in Jamaica, whether it was on the radio, the television, billboards, posters, and postings on social media on the various platforms. And it was to generate interest. And from that, 90 persons expressed an interest in the service, 51 clients being initiated on PrEP from that 90, in addition to those persons who were part of the pilot program in Kingston City, which is the capital of Jamaica. After that, there was a training workshop with different CSO partners in the HIV response, community workers especially, and peer navigators, to introduce them to the concept of PrEP and the messaging and the communication around PrEP. We felt that was important to the way forward as a country, and so that was one of the first things that we did in terms of initiating and providing PrEP here in Jamaica. So like I said earlier, Jamaica AIDS Support, NGO site, is the first site in Jamaica, in Kingston, to provide PrEP for clients. Subsequent to that, it was rolled out in their other 2 clinics across Jamaica, one in Montego Bay and one in St. Anne's Bay. And so far, those are the only 3 sites or clinics here in Jamaica that provides PrEP. So following the pilot program with the Ministry of Health, Jamaica AIDS Support for Life, and CHAIRS, there's a continuation by the Jamaica AIDS Support Jamaica AIDS Support for Life to initiate clients and individuals on PrEP. They are the only agency that continues to do that. And up to July 2021 of this year, 80% of the clients that were enrolled are retained on medication at Jamaica AIDS Support for Life. There has been no seroconversion. And we have had persons, though, that have stopped PrEP, and these were because they had moved, whether to a different country or to a different parish, no longer at risk, pill fatigue, side effects, mainly nausea, and unable to attend clinic regularly based on the expertise of those at the clinic. A way forward in terms of PrEP for Jamaica. Speaking with the Ministry of Health and Wellness representative and the chief coordinators of the HIV program in Jamaica, what they believe is a way forward is a design PrEP program for the country setting based on the pilot that was done. expand PrEP into other civil society organizations to cover all key populations impacted by HIV, develop a monitoring and evaluation framework to measure the efficiency of the general PrEP rollout program in Jamaica, and to roll out PrEP in major HIV treatment sites, public clinics across the island. As well, the continuing advocacy is really important to the expansion of PrEP here in Jamaica, especially the utilization of communities and civil society partners to hold the government accountable. One of the reasons, if I should say, why PrEP has not yet been advanced in Jamaica is because of the bureaucracy process in government, because of the unwillingness to have a conversation with civil society and communities about PrEP and all other opportunities that will reduce HIV infection and help us as a country to reach the 90-90-90. And if you're hearing me say 90-90-90 and not 95-95-95, because as a country, we are yet to sign on to the 95-95-95 because we have a far way to go in terms of the 90-90 targets, as well ensuring access, availability, and monitoring. That is important to this entire process as well. Reduce and continue to eliminate societal enablers that prevents key population from accessing prevention, treatment, and care and support services. If you're aware of the cultural aspect of Jamaica, we have a long-standing issue with stigma and discrimination and human rights violation, which we have a far way to go in terms of putting opportunities, putting measures, putting programs, putting policies and laws in place to protect key population, to eliminate and reduce stigma and discrimination. And that has to be a part of the conversation in terms of moving forward, in terms of ensuring that also PrEP is available for those populations that are still underground, those populations that are still marginalized, and those populations that are unwilling to go out to access prevention, treatment, and care services. Engage communities and civil society in the conversations happening nationally to ensure representation, equality, and equity. Like I would have said earlier, only one partner, one civil society organization currently in Jamaica providing PrEP, and that is because of the unwillingness, dare I say, of the government to push the envelope, to put proper mechanisms in place to protect and provide services for persons who are in need. And ladies and gentlemen, that's the end of my presentation. Thank you.
Thank you so much, Jamoke. At this time, I'd like to present Dr. Carol Nguno. She will present on conducting key population outreach. She is located in Nairobi, Kenya, and she works with the County Department of Health.
Good morning, everybody. My name is Dr. Carol Nguno, and today I'm coming in from Kenya, from the city of Nairobi. And today I'm going to be talking about conducting key population outreaches, what we've been doing in my city. I hope you can all see the screen. Please confirm, that's fine.
We can see.
Thank you. So this is my presentation outline. I just thought I'd share a map of the city of Nairobi. It's not a very big county. Kenya has 47 counties, with Nairobi County being the most populous of the counties. It is also the capital city of Kenya, and so that's where it's located, about centrally. You can see on your right the map of Kenya. That's where the city is located, about 696 kilometers squared of area. So our total city population is about 4.3 million residents who live within the city, but we have about 1 to 2 million people who come in and out daily into the city through the transit, it being a transit city in Africa, through the airports, people coming in to work from the nearby counties. And our male population is about 2.1 million, with females slightly
Hello, Dr. Mojeno. We're having a little bit of difficulty hearing you. It might be just bandwidth on the internet. We'll see if we can continue. You're also frozen. We'll give it a couple seconds. If not, we can try to move on to the next speaker.
2.2 million. Nairobi is contributing to 11% of the cases within the city of Nairobi. In 2019, the city was estimated to have contributed to approximately 10.7% of new HIV infections in the country. This was amounting to about 4,446 people. When we look at the burden of new HIV infections, and just to put into context my presentation this morning, key populations contribute to about 33.1% of all new infections in any given year, with sex workers and clients contributing 14.1%, MSMs 15.2%, and injection drug users at 3.8%. Again, looking at our incidences per 1,000 persons of HIV in Nairobi, it's quite highest among key populations, with 197 among females who inject drugs, 8 among men who inject drugs, 36 among the MSMs, and 58 among the MSW. Sorry for that. The highest number of infections are happening actually around the young adult age group of 25 to 29 years old, and mostly affecting females. However, when you look at the age group of above 40, it is males who have dominated. So I just want to share a prevalence of vulnerable and our key populations within Kenya. And the prevalence among the female sex workers is quite high at 29.3%. Among men who have sex with men, it's at 18.2%. For people who inject drugs, the prevalence is at 18.7%. These are the highest prevalences, considering that the country prevalence rate is actually just about 4.9%. For the TGs, it's estimated at 39.9%. For the vulnerable populations, for us in Kenya, we have the fisher folk, estimated at 31%. We have the truckers, and these are the long distance drivers, estimated at 25%. For people within prisons, about 15.2%, and discordant couples, 15.2%. So that's how the prevalence looks like for the key pops and the vulnerable populations within the country. So just coming down to the city of Nairobi and just looking at the populations of the KPs within the city, we've been able to do some size estimates. The latest size estimate being done in 33 out of the 47 counties. That's 77% of the country, and just counting the key populations. So the Nairobi estimate was 39,643 female sex workers, which contributed to just shy of a quarter of all the female sex workers within the country, with a prevalence rate of 29.3% of HIV. Men having sex with men, about 31% of them, that's about 10,000, live within the city of Nairobi. For people who inject drugs, again, 31% of them found within the city of Nairobi. That's 5,024. And for both populations, a prevalence of above 18%. For the transgenders, having about a quarter, that's 1,074 of them living within the city of Nairobi, with quite a high prevalence rate of 39.9%. And like I said, the county HIV prevalence is 5.2 for all populations. So you can see the real discrepancy. Hence, it's been really critical for us as a city just to address strategies towards being able to target the key populations to reach them with interventions for prevention of transmission, but also management of those living with HIV. So we did the stakeholder mapping, and we've been able to map out the stakeholders within the city of Nairobi. The city of Nairobi is made up of 17 sub-counties, and these are regions that each have a member of parliament, and they all sit together in the National Assembly representing the different sub-counties. And so we've been able to map it to that level and identified the partners that are working with the key populations and the Ministry of Health, and looked at which specific programs. And as you can see on my screen, we have stakeholders in every part of the city. And so we've been able to leverage on the partnerships that we have to be able to increase the resource envelope, to be able to complement the government's efforts to address issues around key population programming. So we currently have 22 drop-in centers and clinics that are spread around the different sub-counties, addressing all aspects. And this is the female sex workers, the men having sex with men, and the PWIDs. Recently, we have had 2 safe spaces added, focused on working with the transgender groups within the city of Nairobi. So it was important for us to have the idea of having outreaches in 2020, and Nairobi has made quite a bit of effort in rolling out interventions to mitigate the spread of HIV among the key populations, and we've scaled up HIV testing services. We've done condom distribution and also lubricant distribution. We've promoted voluntary male medical circumcision, particularly among the men who have sex with men and within the prison populations. We've done a lot of work in creating awareness and increase the sites for issuance of PEP and also PrEP. We currently have about 120 clinics where we can, the citizens of Nairobi can access PrEP and also our key populations. Again, for our KPs living with HIV, we've been able to enhance programs to link them to care and treatment services. However, during the COVID-19 pandemic, we noticed a reduction in attendance to these 22 diocese drop-in centers and clinics due to restricted movement, coupled with financial constraints that came about. Our country went into quite a number of lockdowns, and up to date, we have restricted timings when movement can happen. And this has really affected access to mainstream clinics where services are given for the key populations. So we did some mapping last year of the hotspots and identified about 2,032 hotspots for female sex workers, 369 hotspots for the men having sex with men, and 73 hotspots for the people who inject drugs. And most of these hotspots were identified as illicit drinking dens, bars, and lodgings. However, for the PWIDs, most of these hotspots were mainly located in back streets and alleys within the city. So for us then, after doing the hotspot mapping, again, it made sense to do these outreaches so that we could enhance community leadership of this program, because for this program, service delivery was purely peer-led and within the community setups. Again, they will have strengthened access to comprehensive HIV prevention, care, and treatment to the KPs as it was being provided within their proximity of where they were found. Also, we did these outreaches within flexi hours, hence we're able to fit in with the daily activities of the KPs and particularly the sex workers. So we do even night sort of moonlight so that we'll be able to target them with the services. Again, it made sense because it strengthens outreach to KP communities that are unlikely to seek service on their own, particularly those who are affected, have poor self-esteem, have been stigmatized or marginalized. And so taking the outreaches to them would mean then they would access the service. And again, we know that outreaches really do enhance ownership of HIV prevention services, as their peers, who are the peer educators, are tasked with mobilization, hence becoming the face of the program to the community that is served. So how did we do these outreaches? What was our approach? So for us, the city utilizes the hotspots-based outreaches as a model to provide comprehensive HIV prevention services and differentiated care to the key populations. So we had the WHO, and the WHO really are the peer educators, and this we identified and trained, and then tasked to deliver peer education activities, mobilize and link the targeted clients to the hotspot outreach sites. We also, in the teams, had the skilled healthcare workers and injecting dents, particularly for the PWIDs. We had quite a big population having hotspots in the illicit brew dens, and that's the Chang'ar dens. We call them the Chang'ar dens, and also had some of our sites at the massage parlors. When really these outreaches are planned and conducted, of course, in consideration of KP availability, and a lot of times were targeted to happen in the evenings, over the weekends, and during the late night. And because we were using their peers to mobilize, then we were able to know what time to actually set up, and when we're able to get higher yields and have higher populations of the KPs coming in for the service. So what services have we given during our outreaches, and what are we giving even as we continue the outreaches? We are doing peer education on HIV prevention to reduce HIV risk and vulnerability and reduce new HIV infections. We're also doing condom distribution, and we are doing demonstration as well as providing lubricants. We are offering HIV testing services, both assisted and self-test services. We are giving PrEP and PEP within the outreach sites. We are doing GBV screening and referring appropriately to the nearest health facilities. Again, we are doing STI screening and referrals. We provide family planning services to those who are requiring them at the outreach sites. And we are doing linkage and referral for care and treatment. For some of the stable clients, we've been able to set up outreach sites that regularly go on. And so we are doing community ART refills for some of our stable clients who are KPs. And we are doing harm reduction education and referral for the PWID services at the drop-in centers, and including referrals to our methadone medically assisted therapy clinics. So this outreach approach is actually community-based and acceptable to the targeted population within the hotspot. So what have been our achievements? Just to show you a bit on the numbers and the improvement on the same. So this is a list of the drop-in centers where we offer key population services. And this is a report looking at a year from last year, July, looking at our performance since we started the outreaches. So you can see we did quite well in July to September, but this dropped as the pandemic continued and we went into the surges within the city. Then the distribution dropped from about 454,000 to 408,000. And that's the time when we thought to start the outreaches, and actually started the outreaches in December 2020. And we can see this reflects in an improvement in data looking at January to March 2021, we had an improvement of about 24%, and this in the next quarter, just ended in June 2021, we had a 30% increase in the condom distribution performance to the KPs. You can also see the data there on STI screening, which significantly improved when we started the outreaches. We've not gotten back to where we were last year in July, but we are really coming up from October to December 2020. Looking at Q1 of this year, it really increased by 10,000. And by Q2, we also increased by another 1,000, and we're able to diagnose and link and treat the STIs for the KPs. HIV testing services also showed an increase from Q4 last year to Q1, a slight drop in Q2 this year. Again, we're also offering services for violence screening and support, and the total GBV cases reported has really increased, and we can see the increase is quite phenomenal, with almost a 50% jump between Q1 and Q2 this year. And again, also you can see the numbers of getting the support and getting the referrals for the appropriate support for the GBV. So I just want to show you a few pictures. You can see this is one of our counselors serving and doing testing services at the hotspot. This is a lodging, one of our lodgings within the city. This is at our hotel, a restaurant, Kamba, and this is ART refill to one of our very good clients who is quite stable, and this was convenient to them, one of our peer mentors receiving the service. And this is an example of some of the moonlight outreaches we have done with support from different partners, and the Global Fund helped us to have this van purchased, and we were using it at night, just going into the streets, some of the alleys where the people who inject drugs normally are. And this is one of the trucks that we're using to offer the service. So what are some of the best practices in this outreach service delivery model? We conducted hotel-based outreaches as a model to provide differentiated care to female sex workers living with HIV, and we targeted them for ART refills during the outreaches. Again, we did integrated service delivery. We were offering support for GBV screening and support COVID-19 education, and this was a best practice. Again, it was community-led, purely peer educator-led, so there was a lot of acceptance from the community. There was coordination and partnerships. We worked with the Health Directorate and the City Inspectorate. There was restrictions in movement, but we got IDs and we were able to move in to some of the areas that we could not have gone due to the curfews, but to the lodgings we were allowed to work, so our staff were able to get movement. We were able to give technical support and supervision from the management teams. Again, we observed flexi hours based on the key populations availability at the hotspots, and this really worked for us, the moonlighting. Some of the challenges, we had clients who didn't have face masks, others were masking incorrectly, and we used this opportunity to teach them on those COVID-19 prevention protocols that have been adopted by our country. Again, we had shortage of commodities, test kits and treatment drugs, but we're able to resource mobilize from other partners and be able to reach out to the key populations. We also had insufficient water-based lubricants and not able to meet the demand. Accessing clinical services is also difficult to some of those referred, because we really had to refer for some of the services that we are offering, like the long-term family planning methods, support for GBV counseling to the clinics. And so because of the restrictions and impact on opening and closing times, that became a bit of a challenge. But we followed up those we referred and ensured that they were able to get services appropriately at the time when the clinics opened. Again, initially there was a lot of suspicion, especially by the PWIDs, seeing as the legal issues around them. But because we used their peers, then they were able to come out in their numbers to access the services. Also a bit of a challenge in getting the data into the Kenya Health Information System, because most of our data is facility-based, and we are still working on this because some of the outreaches were done in areas or far away from the facilities, So the catchment population that we ended up reporting was not really reflective of the source of where they were coming from. So that still remains an issue and something we are still talking with the Health Management Information team at the national government. And again, this is an expensive thing to go out and have to take staff out. It's more expensive than the KPs just coming to the site. So we had those fund limitations, but we're, again, as I said, able to resource mobilize. So in conclusion, we know and have tested that this outreach model is good and acceptable to the community. So we need to regularize it and look for support to actually go where the community is and work with the community to help them access services. Also, it's important to come up with a tracking mechanism, particularly for retention to care for clients who we were initiating ART at the hotspots during the outreach, because we initiate and then ask them to report to the nearest clinic. Just if we regularize this, then we are able to keep going back to them wherever they are situated. Again, it's important to integrate clinical services, and some of the plans for us is to actually carry out cervical cancer screening and do screening for other NCDs alongside the HIV testing that we are already offering in these KP outreaches. And very important to embrace, use of virtual platforms like social media and the dating rooms to be able to mobilize for outreaches among the community, because we realized about 20% of like especially the MSMs meet online because of the stigma that is there. So really trying to see how we can utilize these virtual platforms to give them information on where to access the services, and finally, to just improve reporting, to have modules to report on outreaches so that we can reflect populations as per their catchment areas. So thank you very much for listening, and that's the end of my presentation. Thank you.
Thank you so much, Dr. Ngunu. At this time, we'd like to present Nombulelo Magula, who is here from the University of KwaZulu-Natal, eThekwini Municipality in South Africa, and she is and to present on addressing HIV-specific and intersectional stigma.
Good morning, and thank you very much for that warm introduction. I am just, all right. I hope you can see my slides.
Yes.
Yes, we can.
Yeah. Let me just get to slideshow. All right. Yes, thank you for the introduction, Fran. And so what I will do in the next few minutes is I'll go through a historical South African perspective as we speak on the issue of stigma and intersectional, HIV-specific and intersectional stigma. We'll look at the pressure to meet the UN AIDS 1990 targets, and we'll also look at the opportunities for transformation to end the HIV epidemic that are presented by the COVID-19 pandemic. Now, when we're talking about eThekwini, if you are familiar with South Africa and you know Durban, then eThekwini is the differences between eThekwini and Durban is just in the municipal demarcations. So you can picture Durban and the beautiful Durban with the beach. Now, the South African healthcare system is founded on an official racially discriminatory apartheid system. This picture here shows you Eddington Hospital, which overlooks the beach. And this hospital during the apartheid era only provided care for white people. And even if you're a medical student, a Black medical student, you would not be allowed in the hospital. And not very far from here is an more industrial area, is King Edward Hospital that provided care for Black people. And within the hospital, we have an N block that admitted the natives, and it's even today, it's still called the N block historically. And there's an I block that admitted Indian patients. In the middle were the huts, and the huts were an overflow area to admit Black patients. And adjacent to this is a medical school that was opened up to address the pressure to train Black students. So this medical school only catered for Black students, and white students were actually taught in other provinces, in universities that were only for white students. Now, not very far from here is an area called Keitomena. This is where Black people lived and were subsequently forcibly evicted during the apartheid era. They were moved from Keitomena to a township called KwaMashu, and this happens to be the township where I grew up. And this picture here is of a clinic that was there to, for access, healthcare access to people that lived in KwaMashu, which happened to be Black people. Now, fast forward, the HIV epidemic emerged, and with that, we were plunged as a country into what is referred to as HIV denialism. Now, pressure mounted by the time that we started to talk about opening up access for HIV care. This was 2004, and the HIV prevalence amongst women that attend antenatal services, HIV prevalence has risen from 1.6% in 1990 to 40.7% in 2004. Now, in response to this, we then identified spaces where we would roll out antiretroviral treatment, and everywhere you would find that these spaces were identified to be those spaces that were hidden, that were at the corner end of facilities. So in this picture here is the present day King Edward Hospital that I showed you, and tucked away in the corner there, where that yellow arrow is where the antiretroviral treatment rollout program was implemented. And you go to other facilities as well. These HIV services happen to be provided in clinics that are tucked away. And this picture here is of a hospital in another big township in Durban, which is Umlazi. The first township, very big township, KwaMashu, this one is Umlazi. And this is a picture of a hospital, and tucked away in the corner right there where the yellow arrow is where HIV services are provided out of sight. This picture here is of the area that I showed you earlier, where Black people were forcibly evicted, and present day time, a flagship hospital of the province and probably the country is built. And this hospital was commissioned in 2002. But if you happen to be Black like me, and you happen to be unemployed, and you also happen to now be able to live not very far from this hospital, but because you're unemployed and you live in an informal settlement, and you also happen to have HIV, to be living with HIV infection, HIV services are not open for you at this hospital. Not very far from here, about 3 kilometers or so from here, is the King Edward Hospital that I showed you that provided care for Black people only in the apartheid era. So I then conducted, as part of my master's research while I was studying for my master's at Tufts University, Boston, Massachusetts, I looked at experiences of the first 100 individuals that were offered treatment as part of the rollout program when it was implemented in South Africa. And looking at that first 100 individuals, The majority of them were women, 83%, and the requirements to qualify for antiretroviral treatment at the time were quite steep. You had to have disclosed your HIV infection to somebody, have gone through some training and so on to demonstrate that you are committed and so on and so forth. And there was high achievement, more than 90% in all of these areas. People qualified, met the requirements. But if you look at the picture on the right, by 12 months, only 63% of individuals persisted on antiretroviral treatment. And there was a steep drop off in the first 3 months, with about 25% of individuals not even taking treatment after they had met the requirements to be initiated. 5 years down the line, in the same hospital, which happens to be a referral teaching hospital of the city and province, as part of my PhD, I followed up, and here I'm showing you just the group that I followed up over 2 years. And again, I see just looking at follow-up at 2 years, again, there was only 64%, 64, 65% that were still following up on treatment. And in a research context where I was able to follow up participants very closely and did everything possible to find them, I still lost 35% of individuals. And looking at baseline characteristics between those that completed follow-up at 2 years versus those that did not, the one characteristic stood out as to be significantly different was employment. And so if you were unemployed, you were more likely not to complete treatment or follow-up by 2 years. And we also looked at the same teaching hospital. As part of another master's project, we looked at factors that were barriers to accessing treatment long-term. Community stigma was reported in 55% of individuals who reported attitudes of community members to be perceived as a problem. And healthcare facility stigma also was reported as an issue in 25%. And people preferred not to be seen to be accessing treatment or going to facilities. And then we looked at economic factors. Transport was a problem in 52%, and being unemployed was a problem in 65% of individuals in terms of accessing treatment. Now, as a teaching hospital, we're seeing a lot of individuals coming in with complicated tuberculosis, which are consequences of this problem. And we know that HIV and TB are two sides of the same coin. Now, this is a more complicated form of tuberculosis that is more difficult to diagnose and also more difficult to treat. And within a 3-month period, we found that there were 80 individuals in our facility that were diagnosed with extrapulmonary tuberculosis, and 96% of them were Black, and 71% of them were unemployed. And we also found that of those that had HIV infection, which happened to be 88%, 47% of them were antiretroviral treatment naive. And so we tracked down, because this is a teaching hospital that we're talking about, we then tracked down into the community from where patients are referred, which is KwaMashu Polyclinic, KwaMashu Community Health Center, where we went to investigate outcomes of individuals that are treated for the more simple form of tuberculosis, which is pulmonary tuberculosis. And we found, to our surprise, that in the 2 years that we looked at individuals retrospectively that had been diagnosed with pulmonary tuberculosis, the cure rates were 51%, very far from the target of WHO 90% that we should be aiming for. Now, this data was presented at the first Fast Track CT's conference in London as preliminary work. Fast forward, after we had gone through peer review and the work was published, we then visited the facility where these outcomes were identified. Picture on the left is the present day Kwamashu Community Health Center. On a normal day, you will spot gazebos of donor partners that are assisting with screening and testing. And so in engaging the management of the facility to understand factors that might be behind such a poor cure rates in the facility, we're told that it's very easy to screen and test, but there isn't space to then follow up individuals that are diagnosed with HIV infection, tuberculosis, and even mental illness. And they are then made to track down to the old building that I showed you earlier, which is a picture on the right, where they are then having to follow up on their HIV medication, their medication for tuberculosis, and also medication for mental illness, which is about 1 kilometer from this new building that has been put up in the same community. Now, recognizing all of these challenges, now we are in the middle of a COVID-19 pandemic. Our ward rounds today are characterized by seeing, we have patients that have HIV infection, that are living with HIV infection, that have CD4 counts in the boots, and viral loads that are high because of all of these problems that we have highlighted that affect access to care. And they also have tuberculosis, they have pneumocystis jirovecii, pneumonia, and they have COVID-19. And so we are leveraging the pandemic to transform all of these difficulties that we have experienced. We're disrupting the hierarchy of the healthcare system. We're taking specialized skills to the community. We're empowering healthcare workers. Facilities have been repurposed, and we are experiencing that empowered healthcare workers are compassionate, empathic healthcare workers. We're eradicating stigma in the process. And so we also are going to be investigating quality of care as experienced by those individuals that are accessing our services. But with the efforts that we're making to connect with the communities and connect with the community health workers, empowering them and working hand in glove with them, bringing specialized services right into the communities so that we empower our teams, we are hopeful that we will eradicate stigma and everything that comes along with stigma. And we believe that eradicating stigma begins with us. Thank you very much, colleagues, for your attention.
That was a lot to digest. Thank you, Dr. Magulu. All right, I would like to present to you Rodrigo Mojeno, who will speak about optimizing treatment to achieve U equals U. He is from Fundación México Vivo in Mexico City, Mexico. Please unmute yourself. Okay.
Thank you very much, Francis. Good morning to everyone joining us this morning. It is my pleasure and honor to be present in this meeting for regaining momentum ending the HIV epidemic in the US. I thank and acknowledge the work of OASH, Fast Track Cities, and IAPAC, the leadership of Jose, Dashiell, and other team. I'm honored to be sharing this morning with people that I admire and recognize so much as Francis, Jane, Jumoke, Carol, Nambulelo, and Olga. Thank you very much. I will speak in the next 11 minutes about optimizing treatment to achieve U equal U in Mexico. So I'm not sharing any presentation. I thought of sharing this to you as it happened, as the story behind of how we achieved optimizing treatment in 2019. I was part of a group composed of 10 people. We were a combination of doctors, researchers, social leaders, that made this proposal for optimizing treatment. To begin with, I would like to give you a landscape of the HIV epidemics in Mexico. We have, as of 2020, 187,000 registered cases of people living with HIV, of which 50,000 live in Mexico City. As for our advances to the goals of 90-90-90, we have 74% of people living with HIV detected, of which we have 63% of people under treatment, and only 56% of people with viral suppression undetectable. So talking about U equal U in Mexico is quite relevant because we're quite far still from the goal to reach 90-90-90 in 2030. Last year and our yearly epidemics that you can have a clear vision, we have yearly around 18,000 new cases of HIV registered in Mexico, of which only 7,000 cases are detected in time. We still find the big majority detected with AIDS. In 2019, we lived a really great shortage of antiretrovirals in the health system. As February, March 2019, there was lacking of treatments in many places in the country. That you can understand this, how the medical system in Mexico works. Even though we have universal treatment for everyone with HIV, we have a health system that is divided in 5 subsystems of health. These 5 subsystems of health have different coverage over different populations. So by 2019, we were having a shortage in all of the subsystems of health in Mexico. And a group of practicing doctors and researchers joined to make a proposal to the federal government of how we could face this shortage of antiretrovirals in Mexico, being completely afraid of the consequences this could have. As of March 2019, there was no solution how to cover this shortage of antiretroviral treatment. So this group of doctors made a proposal on how we could optimize treatments, how the state could save money by optimizing these treatments. Just that you have an idea, in 2019, the government was buying over 32 different antiretrovirals to be in an infinite amount of combinations for users. Many of these treatments obsolete, and many of these treatments generating damages also to the population receiving them. When this group of researchers joined, they made a very specific proposal to the Ministry of Health of how treatments could be optimized. But at that time, the persons in charge in the government were not having the deep knowledge of the HIV epidemics in Mexico to have an answer. So this group of doctors called to us, to a group of 4 organizations, of civil society organizations and community centers, how could we make it possible for the government to listen to us, and how could this proposal reach the persons in charge who would take the decisions to make it happen. So we all came together to the Ministry of, to the IRS of Mexico to present this proposal, since they are in charge of making all the buying of antiretrovirals nationwide. I must say, in a way, we were lucky to find a very good listener in the Ministry of Health, who was accepting that things were not going right and that things could be done better. And when he saw the legitimacy of the proposal backed up by the researchers, and also the acceptance of this proposal from us, from civil societies, they said, okay, let's try to make it happen. And starting from there, and I say we had a chance of luck because we know that sometimes due to stigma, these subjects are not so easy to address with politicians, but we were lucky back then. And on the other hand, we also had a very strong proposal made by researchers and doctors on how to optimize treatments. So we approached the government to bring this proposal, and the Ministry of Health and the IRS accepted it gladly. But they were very frightened that the population would not accept it. So what we did was making a proposal called Nuevo Paradigma VIH, which was bringing a complete new alternative on how to deal with HIV nationwide. And this proposal, Nuevo Paradigma HIV, was consisting of 4 different goals. The first goal was to reduce scheme treatments, keeping their efficiency, decreasing negative effects in users and interactions. Secondly, to get rid of all the obsolete antiretrovirals that were used at that time. Third, that we could have a supervision of individual specific cases that would require a different scheme of antiretrovirals from their clinics. And finally, and fourth, to guarantee better screening and follow-up in the clinics. Once this proposal was made, what we did was campaigning, and it sounds simple, but it required a lot of creativity back then and a lot of joint efforts. What we did? After we had the support of the government, then there came the negotiation with pharmaceuticals in order to buy these 8 new schemes of antiretrovirals that could guarantee optimizing treatment and find good prices. Of course, the government was concerned mainly how could they save money with this change and how could these savings could be considered. So the negotiation with pharmaceuticals took over around 1 month, but it was not so long because of course the government is buying great volumes of antiretrovirals. So this brings a position in which the government can negotiate. Once we found the right schemes that could be done after searching for all the different details of the users of antiretroviral persons in Mexico, then we made, how can we guarantee the suppliance of these new medicines, and how can we make in such a short time of buying and delivering nationwide to make this change? And this was really a big challenge, and the HIV program of Mexico City played such an important role, because it was actually, it would sound to you as if we were back 50 years ago. The Clínica Condesa, the HIV clinic in Mexico City, was receiving all the supply of these medicines, and depending on the user's profile, distributing how much would go to each of the 32 states, to the 5 different systems of health. And it was really a marathon achieving this, but it was achieved in 1 month with a lot of collaboration from users also and from NGOs. And then once this was happening, what we did was a very strong social media campaign. We wanted to bring these in very clear images and very easily explained to all the users, that they would know that this was in their best interest. So we made a very strong campaign. We launched a site called Nuevo Paradigma, where we explained the proposal and where people could sign support for this proposal. And it was amazing. We reached thousands of signatures in 24 hours of LGBT communities, of people living with HIV, supporting this change. We also made press conferences to have the total support of society, because at that time, we did not only have shortage of antiretrovirals, I must say this, we had shortage of cancer treatments, we had shortage of diabetes treatments in the country. So how can we have the legitimacy and support of all the population that the government is solving the HIV issue first and before solving other health conditions like cancer or diabetes? So we made a very strong campaign with the media and showing how this was in a benefit for all society, explaining how good treatments help us have people with viral suppression and how this helps us farther beyond the 1990 goals, really see on the clear side how we can shorten the HIV epidemics in Mexico. The next part was quite challenging. How do we deliver the specific information to all the practitioners, doctors in the clinics? How do we tell them how to start changing schemes to patients from 1 month to the other, because we had all this new supply of antiretrovirals? And even though we were not so used to Zoom back then as we are now after COVID, we started doing Zooms with every state program. And these researchers that made the proposal were explaining specifically to each state how to change schemes, how to better find out which schemes was better for each user. This took us about 3 months. And then there came the big challenge: how do we convince the other health systems in the country to also take this. And this was a work of 6 months of a lot of lobbying, bringing evidence to politicians that did not understand quite good what we were talking about, but we achieved it. I have 20 seconds left for my 11 minutes, so I will just conclude. After having this achievement for optimizing treatment, I realized that it's always the need to find collaboration from all sectors to get these goals, these hard goals done. We need collaboration from government, from the health system, from community centers, from users, of course, from private sector, from media, and we should keep investing on how to optimize treatments that more people can be undetectable, and therefore we can advance in the 1990 goals. Thank you so much for your attention.
Thank you, Rodrigo. We really appreciate that. We're running a little behind on time, but at this time, I'd like to present Olga Rudnieva, and we're going to hear your presentation, Engaging Community in Delivery and Monitoring of HIV Services. Ms. Rudnieva is from the Ukraine. Thank you.
Good evening from Ukraine. I've heard that we are running a little bit late, so I can fix the issue. I'm gonna be very quick and I'm gonna go through the Ukraine case quite quickly. So I'll start with actually trying to present you the situation with HIV AIDS in Ukraine, because Ukraine used to be and still is the #1 in Eastern Europe on new HIV cases. So basically, the main way of transmission in Ukraine used to be the drug use. We had a very big intravenous drug users population, and through this population, we got HIV to commercial sex workers, and then to general population. That's what we are dealing with for years. We had quite big numbers of HIV transmission from mother to child. Actually, it was not evenly distributed around Ukraine. The Odessa as a port city were more affected. That's where actually HIV entered Ukraine. Big city as Kyiv had always had a lot of cases because many people traveled from small cities to big city due to very big stigma attached to people who are HIV positive. So in a big city, they could actually dissolve and hide and get treatment and get some work. And it was a very, very specific situation. So we were moving from a situation when another 15,000 cases were added each year. And then at a certain point, we were celebrating a very big success in Ukraine when we saw the plateau, when we actually reached the momentum where we slowed down the new cases of HIV due to the very big campaign in media, due to very active lobbying role of our network of people living with HIV AIDS in Ukraine, and due to number of our partners. So we were celebrating the great news, and then the military conflict in Eastern Ukraine happened, and we actually lost part of our territory like Crimea and Donetsk Oblast. And we were observing a huge increase of new HIV cases close to the military conflict territory, due to the rising number of comfort girls and military workers and veterans who are coming back to their families and bringing HIV AIDS. So we are kind of coming to the second wave of HIV epidemic. So it's too early to celebrate the victory. So Ukraine is still coping with HIV at the moment. So let's zoom in to the biggest Ukrainian city, which is Kyiv. Kyiv is quite big. It's the capital of Ukraine. 3 million people live in Kyiv. We only have one AIDS center where people can actually get services. In this AIDS center, you can get substitution therapy, you can get PrEP, and you can actually get a consultation. So it's the only one. If you are living next to the Kyiv, you can go to the Kyiv Oblast Center. Not very convenient, not very easy to access, but that's what we have. Due to that fact, we have a very big number of community organizations, foundations, and networks of people living with HIV AIDS that's supporting people on their way of getting treatment and support. You can see the comparison between different years like 19, 20, and 21, and you can see the increase of new cases of HIV. And we should say that this increase connected to increased number of HIV tests that were done collectively by the number of organizations, not only by the government. Also, we were observing a big number of new HIV cases due to COVID. These people that already had HIV maybe for 5, 6, 7 years, never knew about that. And due to COVID, they were diagnosed with HIV because their whole health situation went bad. And then we realized that they have HIV. So we have increasing number of HIV cases, and we have them due to COVID. If we are talking about 90 goals, we are somewhere not too far away, somewhere too far away. We have 77.2% people who know their HIV status. So this is our biggest goal, to get people tested, because this is the biggest problem to actually diagnose people. 81% people know their HIV status and get antiretroviral treatment. The actually redirection from the testing to the getting treatment is quite efficient, and we're working together with the government sector, and it's working perfectly. And those people who are on antiretroviral treatment, they can actually choose a treatment in Ukraine. 95% of them have undetected viral load, which is quite a good result that we couldn't actually dream about several years ago. We do, like all our organizations and the government and the Kyiv city administration, we do understand how we can do better. We understand that we need to go to the key populations, and we need to test people. We need to promote testing among general and among risk groups. It's more or less fine with the general population, because we run campaigns that talk about importance of HIV testing, and it's a little bit hard to reach the risk groups and hard to reach populations like drug users, and commercial sex workers and men who have sex with men, due to the very big stigma attached to MSM and LGBTQI groups in Ukraine. We recently had a parade in Kyiv, and for the first time it was quite safe, no accidents. But if you look at the parade, it was a metal box surrounded by the police, and people were inside of this box moving around the city. And yes, it was quite safe, but they were absolutely like taken in the loop of the police. That another demonstration of the fact that men who have sex with men, LGBTQI people, and those who are friendly to these groups are still at risk, and they are still afraid to come and ask for services because they don't understand the attitude. We understand we need to put people on treatment because treatment is available. We need to increase awareness about PrEP because people still have lots of questions. What is PrEP? How to use it? How often? So we need to promote PrEP since it's available and it's here. We just need to deliver it to those who are in need. We are very much in need of the sexual education in school because we are still having the orthodox views when you can actually talk about safe sex, but you cannot show the condom and stuff like that. So it's getting really crazy. So we actually took all sexual educations out of schools to the centers like ours, and we ask schools to bring kids to the centers like ours for sexual education. Increase access to free condoms because they're quite expensive. And we need to support substitution therapy, which is also available. And we need to design more services for women because almost all services in HIV AIDS in Ukraine has always been designed for men, because at the very beginning of the epidemic, we predominantly had men as a main client. And as a tradition, we still have services customized and designed for men, and they're very uncomfortable for women to receive. So we're still working on customizing services for women with kids and just for females. What we actually do as a private foundation, we decided that after running for almost 12 years very big social campaigns in media, we decided to put our roots in Kiev and do more for Kiev and Kiev population. So we collaborating with the Kiev City Administration and opened the first community center, which is called Dialogue Hub in the heart of the Kiev, in a very nice location. And people can get HIV testing in our center. They also can get hepatitis B and C testing. We found it very easy to get people tested for HIV if we provide hepatitis B and C testing, because for some reasons, hepatitis B and C has less stigma, so people are more willing to take hepatitis B and C testing. We do sexual education. We do it for small children, starting from 5 years old, when we talk about their borders, about some rules and safety. We talk to schools depending on the age. We also work with school teachers, and we work with parents. So we have separate lectures for different groups, and it's always marked for which age is the lecture. We also run sexual education camps for kids aged 11, 16 during the vacation period. They're very, very popular, but they are limited in number, especially during the COVID time. We give out free condoms because we cooperate with main condom distributors in Ukraine. So anyone who actually entered in our center can get a free condom. And we redirect people who get positive result for HIV tests to Kyiv AIDS Center. What our partners do at the same time, due to the lockdown, we realized it's very hard for people to get antiretroviral treatment. So our partners network of people living with HIV AIDS, who are 100% live at the moment, they were sending antiretroviral therapy and substitutional therapy via mail. So more than 10,000 people got their parcels and got their treatment. They were not able to leave their houses, but they were able to receive their treatment. Our partners do the same with HIV tests. If you want to get an HIV test, you get free HIV test via mail. It'll be delivered at your threshold, and you can test yourself. You can do salvia test, you can do blood test at home at very convenient conditions. Also during the lockdown, 100% live worked with incarcerated population because we had to deliver services to prisons during the lockdown period. And we actually kind of recruited people who are in prisons to work with incarcerated population. Our partners were very effective in redirecting people to the Kyiv AIDS Center after they were diagnosed. Up to 95% of people who were diagnosed with HIV were redirected to Kyiv AIDS Center. Partners also started outdoor campaign in Kyiv to promote antiretroviral treatment. It's called Undetected Untransmitted, and they also do it in cooperation with Kyiv City Administration. All city lights and city blocks are absolutely free of charge, just as well as our premises here. It's free of charge because Kyiv City Administration is very, very interested in building partnership with foundations and community organizations. And also we realized that during the COVID, we cannot actually serve people on the regular basis, as I've told already. So we moved a lot of our campaigns in YouTube, in Instagram, and in TikTok. So we launched a very big platform where we're running very efficient videos about safe sex. We also involved Ukrainian celebrities like pop stars, TV presenters, and covered a very big audience by talking about safe sex with Ukrainian celebrity, talking about the ways how they talk to their kids about safe sex. And we also did Instagram lives to talk about things that are very, very important. So basically, now we are using all this experience that we gained during the COVID period, and our services became more multi-format. Now we are actively using our offline activities, and also in parallel, we are running a number of online activities and delivering services by mail. And the main issue for us right now is to run a national campaign to involve more people in HIV testing. I guess this is it. I think I kept my promise and I was very quick.
Thank you. You were quick. We appreciate that too, but we'll have some questions for you. All right, so thank you. It concludes all of our panel presentations. We'd like to open for some questions at this time. The first question I'd like to propose to Jumoke Patrick. Have you identified a population that was not being served before? And please unmute yourself.
Hello, could you repeat the question?
I said, have you identified a population in Jamaica that was not being addressed before?
Well, if you know the history of Jamaica and the HIV response, the communities that are not addressed or not reached are those communities that are said to be marginalized. For example, men who have sex with men, the transgender community, female sex workers. So those are the communities that really were targeted for the PrEP program and are being targeted now for the PrEP program. And like I said earlier, based on the HIV prevalence among those communities, that was the starting for the pilot. And obviously because of the HIV rate among the community, and obviously because members from the communities kept on asking about PrEP, insisting that we started to provide PrEP based on what they would have heard or seen from social media or mass media, based on traveling to different countries and seeing the different offerings that are provided. So it was from those conversations and from those data and information that we targeted those communities. But by and large in Jamaica, when we talk about HIV, when we talk about stigma and discrimination, it's largely those communities that are said to be different or said to be not accepted that we're targeting for the PrEP program.
All right, thank you, thank you. And Dr. Nguno, Carol Nguno, I'd like to ask you a question. You mentioned the Moonlight Outreach. So I was wondering, how are you reaching the younger population in your country? Unmute yourself, please. Carol, unmute yourself, please. There should be a button in the lower left corner of your screen.
Thank you. Yeah, I think it's restricted, but yes, thank you for that question. So yes, we were doing Moonlights, and these targeted outreaches, like I said, were within the hotspots, and just looking at the percentage population that were actually the young key populations and the ones we are actually targeted, we have about 20% of them being actually under 18. And this we are calling most at risk adolescents, and we are still offering them these services, including testing as emancipated minors without necessarily getting the parental consent. But we are also working within the DREAMS programs, which are targeted particularly for adolescent girls aged 10 to 24 years, and we are working with them within the safe spaces in the informal settlements and also targeting outreaches that are specific to these young girls. Thank you.
And what is the age of consent?
15 for now, 15 years and above.
Okay, all right, for testing?
Yes, for
okay,
testing, yes,
that's
yes.
very good. All right, thank you. Now, Dr. Magulu, I'd like to ask you a question. What are the main barriers? You presented a lot of barriers in South Africa to testing. What are the main barriers you see, including prevention services?
Yeah, so I think the main ones really relate to stigma as experienced by people that must access services, and that stigma comes in different shapes and form, and people actually have to travel far to access care because they don't want to be seen in their own communities. And we're seeing that even now with the COVID-19 pandemic, where people have difficulty actually even accessing testing for this disease because they fear that they are going to be, even assaulted. That we are a very violent society. We have a history of people that live with HIV that have been killed because they were just because somebody was infected with HIV. So they run deep, and as I indicated, I wanted to highlight the legacy of apartheid, which is still embedded in our everyday life. And you will have seen recently the violence that erupted in the country. All of these are all the socioeconomic factors that underlie the challenges that are experienced by the majority of people that live in South Africa, and in eThekwini or Durban in particular, as the city that has the biggest problem of HIV in the world. So I think if we can deal with stigma, we will go a long way and really go deep to understand it, and also go deep and understand the legacy of apartheid and how it manifests in the challenges that we experience every day. Thank you.
Thank you. Okay, and Rodrigo, I'd like to ask you, you presented a number of issues about the purchase of obsolete medication in your country, but if you had unlimited, unrestricted funding, what services would you be able to provide, and what priorities would you serve? Could you unmute yourself, please? Can you unmute? Okay.
Yes, I was waiting for authorization. Yes, there was a saving of over 1,000 million pesos when we made the optimizing of treatments. And what we did was, in order not to lose these resources for health, was also convincing the Minister of Health and the Minister of the IRS that this money should be invested in treatment for viral hepatitis C and PrEP. And as of 2020, we're having a universal coverage of treatments for hepatitis C nationwide. We're very slow in detection still, but there's treatment. And PrEP starts as of the 1st of October as a public policy in Mexico, starting in 10 different states now. It will be gradual. So all the money that was saved is reallocated for STIs and HIV prevention, also for sexual education.
Okay, very good, very good. So Olga, you are next. and you need to unmute yourself.
I did.
You presented an interesting observation about the treatment of LGBTQ individuals in your country. What are your recommendations to address HIV stigma?
Well, we do a lot of campaigns in media, and we also work with LGBTQI community to make them visible and to make them speak. Back in 2007, we even brought Elton John into Ukraine. He came back in 2012 and he came back in 2017, and his main message to Ukrainians was actually about stigma towards gay population. But at a certain point, we realized when it's Elton John talking about gay population, people are kind of, fine with it. But when it comes to real people, the stigma is still very high. So people kind of excuse Elton John for being gay because he's so genius. And they absolutely do not excuse normal people for being gay. So we started sharing their life stories. Recently, we had a veteran from the Eastern Ukraine who were part of the military conflict, who's a veteran, who made a very huge coming out. He said that people who are, fighting in the eastern part of Ukraine as the fighters for Ukraine, they are still, they can be gays. And it was a very big discussion. So our main focus right now is to share stories of LGBTQI and talk to opinion leaders and role models. So we want them to demonstrate that people are different, that's fine, and that's okay. And we are trying to take away the HIV stigma from LGBTQI community, explaining that the main ways of transmission in Ukraine are heterosexual way and intravenous drug use, not homosexual people. It does help, it's changing, it's a little bit better than in Russia, but we're still facing a big stigma. So it's moving, but it's very slow move. And things are obvious in big cities, and they are absolutely not that obvious in small cities of Ukraine. So the farther you are moving from Kyiv, the worse the situation. So big campaigns, role models, real people's stories, and the government attitudes towards the issue. That's what we are working on right now as a community and as Ukraine in a whole.
Thank you so much. As we said in the beginning, there are some very interesting things taking place globally and very innovative things taking place. So, we could talk with each of the panelists for a lot longer, but we're at a time now where we're at our lunch break and we will conclude our section. Thank you.
Thank you, Fran, and thank you to our panelists for joining us today. A big round of applause for everybody, but unfortunately, we are tied to a little bit of time constraint to everybody else who will be attending our part 2 of the day. We'll be logging off, and you'll log into the day 1, part 2 join in link. We'll be returning at 12:30. For our domestic panel. Thank you very much, and we'll see you back